In part 2 of gastrointestinal system. So let us start with portosystemic anastomosis. So this anastomosis actually happens whenever there is increased portal tension. So when portal tension can increase whenever there is any liver problem. So whenever in liver problem, the portal tension will increase and that will lead to systemic anastomosis. So the first site is esophagus. So some people are getting the blood as vomiting because of the esophageal varices. That is because of portal hypertension. So from the blood from the portal system is entering into the esophageal veins, and that is leading to the increased pressure in esophageal veins, and that is esophageal varices. You can see the portal to systemic shunt. In this diagram we can see the pink color as the systemic the purple color as portal system, and the blue color as systemic venous system. So from portal to systemic, here from left gastric to esophageal. So whenever there is esophageal varices, that is because of left gastric veins. This purple color is the left gastric. So from here it is transferring to esophagus, that is the portal hypertension is transferring to esophagus, and that will lead to dilation of esophageal veins so much that the esophageal vein can't bear it and it will rupture and burst, and that will lead to blood which is coming from the mouth. That is esophageal varices. Is a very dangerous condition. Patient can die within very few seconds, so we need to immediately reduce the portal hypertension. Next, coming to the umbilicus, that is the caput medusa. Caput medusa is the second point where the portal hypertension is transferring to systemic hypertension. That is from the paraumbilical vein to the epigastric veins, the tension is going. So that is leading to caput medusa. That is the blood vessels are getting dilated a lot in the umbilicus, and that will lead to caput medusa. So these are the branches of epigastric veins. These are the branches of inferior and superficial epigastric veins of anterior abdominal wall. Next, coming to rectum. In the rectum also this may happen, that is leading to anorectal varices. So anorectal varices is different from hemorrhoids or piles. That is different, and this is different. This is because of portosystemic tension. That is the tension from the portal veins is transferring to the systemic veins. That is here anorectal varices. That is because superficial rectal to middle and inferior rectal veins. So this for this the mnemonic is the varices of gut, butt and caput. Gut means esophagus, butt means rectum, caput means umbilicus. So these are the commonly seen with portal hypertension. So the treatment for this is we do TIPS. TIPS is a surgery, that is a transjugular intrahepatic portosystemic shunt. So actually what we do is we just shunt the portal system, that is from the portal vein to the directly to hepatic vein. So now the blood, we are only giving the way for the blood from the portal vein to the hepatic vein, so that this esophageal varices, umbilical varices and this rectal varices will not happen. So we are only just transferring this pressure to hepatic vein, but there is a problem. That is because of shunting of this blood. Actually this blood is bypassing liver, so because of that it can precipitate hepatic encephalopathy, because we can't clear ammonia from the portal vein which is coming into the liver, because we are bypassing the blood from the liver to the hepatic vein directly. So this may go and accumulate in the brain, and that will lead to hepatic encephalopathy because of ammonia. Now let us discuss about pectinate. So pectinate line is also called as dentate line. Okay, so it is separating the endoderm from the ectoderm. Endoderm is derived from the endoderm of the hindgut, is separated from the ectoderm. Ectoderm, this is also called as proctioderm. Okay, so what are the arteries, what are the veins, lymphatics, nerves, we should understand above the pectinate line and below the pectinate line. So above the pectinate line, the nerve is visceral innervation to inferior hypogastric plexus, that is T12 to L3, and the arteries are superior rectal artery, which is a branch of inferior mesenteric artery. Okay, and the vein is superior rectal vein to inferior mesenteric vein to splenic vein to portal vein. So it is a flow of blood from superior rectal vein, it will flow into inferior mesenteric vein, from there to splenic vein, from there to portal vein. Next, the lymphatics. Lymphatics drain to internal iliac lymph node. Okay, now coming to below pectinate line. Below pectinate line, there is somatic innervation of pudendal nerve S2 to S4, and this inferior rectal artery, which is a branch of internal pudendal artery, and there is an inferior rectal vein which will drain into internal pudendal vein, and that will drain into internal iliac vein, and from there to common iliac vein, finally to inferior vena cava. And this lymph node will drain to superficial inguinal lymph node. So these are very important. What are the structures above pectinate line, below pectinate line? And now let us see what are above pectinate line is called as internal hemorrhoids. They are derived from hindgut and mainly of columnar epithelium, and they are of adenocarcinoma type. Remember that internal hemorrhoids are not painful. Why they are not painful? Because they receive the visceral innervation. Okay, because of visceral innervation they are not painful. And if there's abnormal distension of anal venous plexus, then the risk factors include older age, chronic constipation may lead to this problem. The problem is abnormal distension of anal venous plexus. Okay, below the pectinate line is from proctodeum ectoderm. Here this is a stratified squamous epithelium. Here these are called as external hemorrhoids if the hemorrhoid form here, and also anal fissures can form, squamous cell carcinoma can form here. External hemorrhoids are mainly receiving the somatic innervation. Because of somatic innervation they are painful if thrombosed, and they are supplied by inferior rectal branch of pudendal nerve. Okay, so that's why they may be painful. Anal fissure is a tear in anoderm below pectinate line, and the pain while pooping blood on toilet paper located in posterior midline, because this area is poorly perfused and it is associated with low fiber diets and constipation. So constipation may lead to all these problems. Imperforate anus is absence of anal opening. So these are GU malformations. So there is renal agenesis, bladder extrophy, failure to pass meconium, and meconium is passed by urethra or vagina. This because of formation of fistula. Meconium should pass through anus, but because of fistula it is passing either to urethra or vagina. So actually above the pectinate line types of hemorrhoids are associated with portal hypertension. Because of portal hypertension, then they may affect the above pectinate line hemorrhages. Now let us discuss about liver tissue architecture. So the main functional unit of the liver is this hexagonal shaped arranged lobules. So this is containing a central vein, and also it is having a portal triads on the edges, you can see. And this is consisting, this portal triad contains mainly portal vein, portal artery, and bile duct, and also some lymphatics are associated with this. Actually it has an apical surface and basolateral surface. Its apical surface is in connection with the bile canaliculi, and its basolateral surface is in connection with the sinusoids. You can see these are the sinusoids, this purple color, this is sinusoid. And there are Kupffer cells in the sinusoids which are specialized macrophages, and you can see this one, these are specialized macrophages which clear the bacteria and also damage senescent RBCs. So extravascular hemolysis occurs in the liver, we say, where because of Kupffer cells, because it removes the senescent RBCs. Next, coming to hepatic stellate I2 cells. So these are the I2 cells which are present in space of DC. This is a space of DC. So here they are present, they store vitamin A when they are quiescent, but they can produce extracellular matrix and also get fibrosed in the case of hepatic fibrosis. That is a stellate cells. They are responsible for hepatic fibrosis, especially in cirrhosis condition of liver. Stellate cells get activated. So this liver is containing actually 3 zones: zone 1, zone 2, zone 3. Zone 1 is a periportal zone. It is affected first by any infection, viral hepatitis, because you can see it is away from the central vein and it is nearer to the blood vessels. Okay, so viral hepatitis may be affected here, and it is best oxygenated because you can see this artery, the artery is hepatic artery is here, and it is most resistant to circulatory compromise because it is near to the artery. Whenever there is suddenly any ischemic condition to this artery, then it will be most compromised, and ingested toxins like cocaine can also get affected first in the zone 1. Next, coming to the zone 2. Zone 2 is intermediate zone. Can you remember zone 2, right? 2 like yellow fever, double L there. Okay, and next coming to zone 3. Zone 3 is called pericentral area, which is nearer to the central vein. This is centrilobular zone. It is affected first by ischemia because it is so far away from the blood supply, right? It is least oxygenated zone, and there are high concentration of cytochrome P450, and this is the most sensitive to metabolic toxins like ethanol, CCl4, halothane, rifampin, that is acetaminophen. For all this, and this is also a site of alcoholic hepatitis. So whenever this alcoholic hepatitis, it is affecting zone 3. Okay, so next coming to biliary structure. So before understanding the biliary structure, we need to understand about the pancreas and also this duct. Actually, common hepatic duct meets with the common bile duct. Okay, actually this is a cystic duct coming from the gallbladder. This is a common hepatic duct. Common hepatic duct with cystic duct form the common bile duct. Excuse me. So this common bile duct actually joins with the main pancreatic duct. You can see here, this is the accessory pancreatic duct. So main pancreatic duct, common bile duct, all open at sphincter of ampulla of water into main pancreatic duct. Okay, so into sphincter of into ampulla of water, and there is a sphincter called sphincter of Oddi. Okay, so this is what we need to understand first. Now let us go. Actually, cholangiography is a study which we do for this filling defects in gallbladder. So here you can see this is a filling defect in gallbladder, that is a cystic duct is not proper. Okay, and next coming to gallstones. Gallstones are which reach the confluence of this common bile duct and the pancreatic duct at ampulla of water can easily block this both ducts are blocked when it is at that site. That is causing double duct sign, that is causing both cholangitis and also pancreatitis respectively. Cholangitis means this duct, duct which is continuous with the cystic, that this hole will get inflamed, and also the pancreatic duct will get inflamed. That is called double duct sign, because this is getting in, this is getting inflamed, two ducts are getting inflamed. And the tumors also sometimes arise in the head of the pancreas, and that will also affect this ductal adenocarcinoma can cause obstruction of both common bile duct, and that will lead to enlargement of gallbladder with painless jaundice, and that sign is called Courvoisier sign. That is obstruction of common bile duct, enlarged gallbladder with painless jaundice, Courvoisier sign. And one more thing, sphincter of Oddi dysfunction seen in pancreatitis, gallstone disease, that is leading to biliary symptoms like right upper quadrant pain. Treatment is calcium channel blocker, nitrates, and also you can cut down that sphincter. Morphine will cause spasm of Oddi, and demerol is a meperidine treatment for acute pancreatitis. Okay, ampulla of water empties into major duodenal papilla, and sphincter of Oddi is a muscular layer. Now coming to femoral region. So femoral region, blood vessels are arranged according to the mnemonic navel. You can remember the mnemonic NAVEL. N stands for the femoral nerve, A stands for femoral artery, V stands for femoral vein, E stands for actually E is nothing, just to remember I put that. L stands for lymphatics. So you can see lymphatics. So they are in order: femoral nerve, femoral artery, femoral vein, femoral lymphatics. So you can remember navel as a mnemonic, or you can remember venous near penis. Venous near penis means you can see the vein, the femoral vein is near to the penis, like it is towards the medial side. So this is from the lateral to the medial side of a femoral region. So femoral region have mainly two important structures. One is femoral triangle and one is femoral sheath. Let us see. So this structure you can see here, this is a femoral triangle. Femoral triangle boundaries are like superior, you can see there is an inguinal ligament, and medially there is adductor longus muscle. Okay, and laterally you can see there is a sartorius muscle. And the structures we know, navel structures. Okay, and next coming to femoral sheath. Femoral sheath is below the inguinal ligament, and remember the important thing, in femoral sheath there is no nerve, no femoral nerve is present in femoral sheath. Femoral nerve is present only in femoral triangle, but in femoral sheath no femoral nerve. And there is a femoral ring, you can see this ring structure, it is a site for femoral hernia, like abdominal contents may pass through this ring if there is a formation of hernia. And femoral sheath is a fascial tube 3 to 4 cm below inguinal ligament, and it contains femoral vein, artery, and deep inguinal lymph nodes, but no femoral node. Deep inguinal lymph nodes are present in the femoral sheath. Femoral sheath have deep inguinal lymph nodes, femoral vein, artery, and also canal, but no femoral nerve. And one more important structure which you can find here is that is inguinal or Hasselbeck triangle. You can see this is a Hasselbeck triangle which is like above the inguinal ligament with hernias. So because we need to understand hernias, we need to understand inguinal canal. So first we need to understand what structures are passing through inguinal canal, and they're passing through which structures. So first you can see this is a deep internal inguinal ring, okay, and this is of parietal peritoneum, extra peritoneal tissue. This is a transversalis fascia, and this is a transverse abdominis internal oblique aponeurosis of external oblique and inguinal ligament. So from here first hernia passes, and from there it passes to transverse abdominis muscle, internal oblique muscle, aponeurosis of external oblique muscle, finally passing to superficial inguinal ring, and it comes out. Actually this is a normal structures which are passing through inguinal canal, that is you can remember it as ICE. Why? Because it has internal spermatic fascia, cremasteric muscle and fascia, external spermatic fascia. So internal cremasteric, external spermatic fascia. Internal spermatic fascia is having transversalis fascia along with it, cremasteric muscle and fascia having internal oblique muscle with it, external spermatic fascia having external oblique muscle with it. Okay, cremasteric is having internal oblique, external spermatic is having external oblique. So all these are carrying through inguinal canal. So first you need to have this idea. Now let us understand indirect inguinal hernia and direct inguinal hernia. So indirect hernia is just following the same path. That's it. Very simple. It is traveling lateral to the inferior epigastric artery. Okay, this is lateral side, this is medial side. So these are the inferior epigastric artery. They are traveling lateral to inferior epigastric vessels, and from there they pass both through deep inguinal ring and also superficial inguinal ring, as they are following the same pathway as this internal spermatic cremasteric muscle, external spermatic fascia. These three are also present along with the indirect inguinal hernia. Okay, so the important thing which you need to remember here, it is most common on right side, and that too it is most commonly seen in children, because in children process vaginalis is open. As a process vaginalis is open, so that in newborn it is having very higher chance, and also in adult who are doing heavy lifting or you are straining defect, they may have defect through this, and that may lead to indirect inguinal hernia. Important thing, it is most common in males. Okay, indirect inguinal hernia is most common in males. Actually, what is a hernia? It is a protrusion of peritoneum through an opening, usually at the site of weakness. Contents may be at the risk of incarceration, that is they are not able to go back into abdominal pelvis. Once they come out, that's it, they just come out, and they may undergo strangulation, that is they may undergo ischemia and necrosis. Complemented hernias may sometime even present with tenderness, erythema and fever. So this you can say this is an indirect inguinal hernia which is seen in a small boy. Next we'll discuss about direct inguinal hernia. This is very simple. Direct inguinal hernia will be medial to inferior epigastric vessel, but important thing, it moves lateral to rectus femoris, rectus abdominis muscle. You can see rectus abdominis, lateral to rectus abdominis, medial to inferior epigastric vessel. This is the site, you can see, abdominal wall site of protrusion of direct hernia. So actually it passes only through the deep inguinal ring, but it will not pass through the superficial inguinal ring. So as it passes only through deep inguinal ring, it has only external spermatic fascia, but no other linings are present. It never bulge into scrotum, and it passes by only one ring. Okay, and this is passing through Hasselbeck floor or transverse fascia, transversalis fascia. You can see this is a transversalis fascia, so it passes only through transversalis fascia or Hasselbeck triangle, so directly bulging into the parietal peritoneum, medial to inferior epigastric vessels. And this direct hernia is mostly seen in older males due to acquired weakness of transversalis fascia. In older male, already this blue color is very weak, that is transversalis fascia, so that will lead to this. Next, coming to femoral hernia, you can see here this is a hernia coming directly from the femoral ring, you know the femoral ring, right? So from that it comes, it is medial to femoral vessels. You can see these are femoral vessels, so medial to that this comes, that is the intestinal loop beneath the inguinal ligament. And this is most common in females. How to remember that? Femoral, females. And one more thing, it has most common cause of strangulation and incarceration when compared with inguinal hernia. That is, it may undergo ischemia and it will never go back into the abdomen again. Femoral hernias are having this chance more when compared with inguinal hernias. One more thing, femoral hernia is lateral to pubic tubercle. Now let us start with diaphragmatic hernia. Diaphragmatic hernia is most common on left side because right side liver is there. It's like somewhat protective, but left side it is mostly present because of weakness between the diaphragm and the abdominal contents. So the abdominal contents are trying to go up. In this diagram you can see clearly abdominal contents are going into the diaphragm. This is because of congenital defect of pleuroperitoneal membrane. Here will be the pleuroperitoneal. If that is defective, then it will lead to this. In utero, this condition will also lead to pulmonary hypoplasia, and it is often fatal because this pulmonary hypoplasia, lungs are getting compressed because of abdominal contents going into diaphragm. And in adults, there may be the phrenoesophageal membrane defect. When the phrenoesophageal membrane is defect, you can see here that is causing hiatal hernia, that is herniation of stomach through esophageal hiatus, and this is a gastric cardia which is into the esophagus. So it is a sliding hernia which is most common hernia. It is also called hourglass stomach, and it's the most common type associated with GERD, that is reflex. Okay, and paraesophageal hernia means not directly through the esophagus, but on the side the hernia takes place. That is the gastric fundus is herniated here. Here the gastric cardia is getting out. Major risk factor for this hourglass hernia or hiatal hernia is obesity.